You know, over the years, Dr. Cavanaugh has brought some fascinating guests. We've had people always in the news about different health issues that were going on, and you may have outdone yourself this morning. Tell us who you have lined up for us.
Well, I'm very pleased they were able to take out time to come and be on the show. It's Dr. Hooman Noorchashm and his wife Amy Reed. These are the two physicians that have really exposed the problem of a surgical procedure which has the potential of making cancer worse and spreading it. And it's due to a device called a Morcellator. And I'm sure he'll explain the ins and outs and what that device is. But it's not only fascinating on, how this got approved, on how it's still on the market, and it really gives insight into the safety of medical devices just in general. I mean, it has many ramifications. But this is just a heart-wrenching story. This happened to his wife. The reporter who exposed this story, and it was from the Wall Street Journal, and this reporter, as I had said before, was nominated for a Pulitzer Prize.
On this story?
On his story, yeah.
Wow.
So this is a huge issue.
Good morning.
Good morning.
Thank you.
Good morning.
Thank you both for being with us. They are in two different places, I guess. Now, where are you folks?
I'm in our home in Bucks County, Pennsylvania.
Pennsylvania, yes, sir.
And I'm in Philadelphia right now, taking some time out of work.
Okay, well, good. Well, it's very good to have you both with us. Kevin?
Thank you, sir.
Yes. Well, why don't we, start off and Dr. Noorchashm, just tell us a little bit about the Morcellator and yourself and your wife's story, and give some background to the viewing audience. And this is for a very common procedure, and that's of a hysterectomy, or removing a uterus. I mean, it's not an uncommon procedure that this would be used for.
Okay.
Right. Well, so Amy and I are both physicians. I'm a heart surgeon in the city of Philadelphia. Amy's an anesthesiologist in the city of Philadelphia, and I think Amy will probably be able to tell you better what her personal experience was and what this device entailed. But essentially, very unfortunately, in 2013, we not only came across a surgical complication that affected us, but in the meanwhile, we're able to identify a very significant public health hazard, which, with the help of the press, we were able to expose and get some federal action on. So I'm going to let Amy and talk about the Morcellator and what the issue is.
Would you spell that for us?
Yeah, the Morcellator is spelled Morcellator.
Okay, Morcellator. Yes, sir. Amy?
Yes, good morning. I can tell you a little bit about my personal story that unfortunately is is shared with women across the country. We had 6 children, and during one of my pregnancies, I was told I had fibroids.
Told you that what? I'm sorry.
I was told I had fibroids.
Fibroid. Okay.
Fibroids, which are very common. They're just benign, meaning harmless growths in your uterus, and they kind of told me in passing. But when I was pregnant with my 6th child, I began having discomfort, and the fibroid began growing, and everyone told me, oh, this is normal, this is normal, this is normal. After the birth of my 6th child, I had a lot of issues with very heavy bleeding, and again, I went back to my doctor, and they told me this is normal, this is normal. If you wanted to stop, you should consider either taking out the fibroid or taking out the whole uterus and having a hysterectomy. And so we went the route of having a hysterectomy, and they said, oh, we'll do it through these little incisions, you'll do great, you'll be back at work in no time, back home the same day, which I was. But 8 days later, we got a phone call, sorry, you have cancer. It was sarcoma. And when we asked in a little more detail about how they took out the cancer, and they told us that they used a device called the Morcellator, which chops up the tissue into little pieces so they can get it out of these little holes. And the problem with sarcoma specifically is when it's cut up, it often just spreads.
Yeah, so Jack, if I may, this device essentially looks like a drill, and it's essentially a meat grinder. It goes into the abdominal cavity through a small incision, and basically the tissue that's been dissected by the surgeon gets sucked into this meat grinder, and it grinds up the tissue to suck it out of the small incision. In the process, all the bits and pieces of tissue spread all over the abdominal cavity. Now, if there's cancer in there, that cancer is essentially just spread throughout the abdominal cavity. Now, this was something that was very unique to gynecological practice. Other surgeons, I trained as a general surgeon, cardiac surgeon. We don't practice that particular technique, and certainly it's not on any general surgeon's radar screen as a routine standard of practice. Yet the gynecologists had accepted this as a standard of care, and for the past 20 years, really, even over 20 years, they've been practicing this as a standard of care, and making this assumption that these women's tumors, uterine tumors, are benign. That's an assumption that we've termed the assumption of benignity. Now, if you make the assumption that tumors of the uterus are all benign, there's going to be a certain fraction of them that are not benign, and in those women, the cancers were being spread. Of course, the GYN surgeons were making a gross underestimate in terms of the frequency of this disease process. The frequency that they were quoting for women, if they did quote it at all, was 1 in 10,000. What we subsequently found through a review of the literature, actually, and reported to the FDA, was that the incidence was actually somewhere on the order of 1 in 250 to 350.
Oh, gee.
So, yeah.
Well, obviously we're going to talk more about this horrible thing, this Morcellator business, but how are you, Dr. Reed?
Well, I went into this in pretty good health, and I think that's helped. I've had 4 surgeries. Most recently, they took a spread of this cancer from my back, so I had back surgery with some rods put in. That wasn't too pleasant. So I've had 4 surgeries and 6 months of chemo. I've done radiation, but again, I went in very good shape. And so far the sarcoma has been slow. There are women who had their surgery after I did, who also had their sarcoma morcellated, who since have passed just because they're spread so rapidly. So, I mean, all things considering, I think I've been one of the more fortunate ones.
Oh, that's good.
Jack, I got to tell you also that one of the characteristics of my wife is that she's extremely optimistic, always has been. She's the mother of 6. She has 2 doctorates, an MD and a PhD. So basically, I mean, she's approached this disease process with an incredible amount of energy and optimism, and I think that's sort of what's brought us through. But she's been through an incredibly harrowing experience on all levels. So I think we're poised to beat this thing, and we will.
One of the frustrating things I've had is that, and I've seen this in other categories, you can even talk about infectious disease, is that you have this money-making forces or influence that tends to generate just an incredible amount of papers and rebuttals and reasons why we can't do this, et cetera, in very prominent medical journals, so that even though these disasters are happening, you still see papers and editorials that say, we need to keep this on the market. We need to still use this device.
Absolutely.
We just need to do proper education of the patient before surgery.
Absolutely.
I mean, it is absolutely ridiculous. And it's just junk, trash research being in prominent medical journals that they're then able to justify keeping on business as usual. And
Kevin, I have to tell you, I mean, this experience for both Amy and I has been very enlightening, and I'm sure Amy's going to touch on it, on the informed consent part of this, which is the concept that you can protect patients by informing them of this risk. I think Amy will touch on that, but the comment I want to make is that what I was struck by in terms of the defense of this practice. I mean, this is a multi-billion-dollar practice that, fortunately, for the most part, at this point, a year and a half later, we've managed to basically eliminate, I think, for the most part, from the United States. But the defense of this practice by the gynecologists was, to me, very striking, and I think it's very telling, and I think it's probably a systemic problem throughout medicine and perhaps throughout our country, is that, number one, that this practice is benefiting the majority, and therefore it's justified. Okay, so it's this utilitarian argument that says if something benefits the majority, even if it's avoidably harming a minority subset of people, it's okay to engage in this. This is what the sort of corporate infrastructure, if you will, in gynecological surgery and in the industry argued with us about. And the second argument that they used was that this is a woman's choice. So in other words, if a woman wants to walk out with a small incision, that's the choice that she has to make, not accepting the concept that there is such a thing as bad medicine. For instance, what comes to mind is when Michael Jackson was treated with propofol by his treating physician. Well, he consented to the use of that drug, yet it was an inappropriate drug to be administered. So, bad medicine should never be a matter of choice. And so these two defenses, benefit of the majority and a woman's choice, has been used to defend what is a deadly practice to a minority subset of people in this country.
Wow, that's just phenomenal. Thank you. We're going to take a break. Just a phenomenal story this morning. Dr. Kevin Cavanaugh, I almost always begin the program, and I didn't this morning. I was too excited about our guests, by saying that you are a founder and very involved with an organization called Health Watch USA. Tell us what that is.
Yes, well, we're a nonprofit organization, and it's rapidly growing this year, that is kind of devoted to patient safety, also to healthcare transparency of both quality and cost. And we try to foster both not only publications in the medical literature that looks at research integrity issues, but also conferences, talk shows such as we're doing today, to kind of get the word out about some problems, the systemic problems in our healthcare system.
And the one we're talking about today, we would like to think it's just this one problem. It's not. You say there are lots of other problems like this one, and you even got members of your organization that are involved in it.
And we have several members now. This is, I think, probably one of the most horrendous examples of a medical device problem. But the problems with medical devices, and I think Dr. Noorchashm will talk about this in the 510K approval process when we get back from the next break. This is a short segment.
Yeah.
Just infiltrates all of the decision making in medicine, unfortunately. And we've got several other examples. For example, the spreading of the deadly bacteria, CRE, using the types of flexible diagnostic endoscopes. They're called duodenoscopes or retrograde scopes, and the FDA not being alerted to problems about that. You also have the problems that Dr. Steve Tower has reported of metal poisoning from some types of hip implants. This happened to him himself. It was reported out of Alaska. And it all evolves around the FDA, the approval process, inadequate testing, and it's just not this one area. Although this is probably one of the most horrendous areas, because this is a very common procedure in striking down very young people. And despite that, it's still on the market. Even though in the U.S. its usage has been curtailed and is going down dramatically, the device has not been pulled. Some of the companies, I think, have pulled it voluntarily. And then you read some of the articles or the research articles in the literature that are justifying this procedure to continue. It just gets you to pull out your hair. It's as long as the patient knows about it, they know the risk, it's okay to do.
And I guess as a non-doctor, as just a regular person, you're thinking, we've got two brilliant doctors on the phone here, and if that can happen to them, just think how that could happen to somebody like me that knows almost nothing.
Well, don't think because you're a physician you're immune to problems in the medical system, number one. And number two is, medicine is very complex, and so when you're a physician or you're a specialist, you'll know your one little area, but you're almost as clueless as the general person on the street if you get out of your field.
Out of your field, that's right. Let's go to the phones. This is Lynn. Good morning, Lynn.
Hi. Yes, I was just listening to your program, and I was wondering, when you're talking about the Morcellator, the procedure where they do like for endometriosis, where they go in there with a laser and cut all that stuff away, is that dealing with anything like that, or?
Okay.
So I think the procedure you're talking about is when they go in externally, meaning through your
I tell you what,
vagina.
hang on just one second. Lynn, I'm going to let you listen off the air. We're getting some bad feedback. I'm sorry. Go ahead, Amy.
So I think you're describing a procedure where they go in vaginally and treat the endometrium like that. That typically absolutely does not involve the tool that we're talking about, because there they can just take what they need to through the vagina, and it's not like they're going in through your abdomen, through your skin. So I think that's a different procedure.
Dr. Kevin Cavanaugh is with us, as he is every month. And Dr. Hooman Noorchashm and Dr. Amy Reed, they are husband and wife. They are on the phone with us this morning. In case you just joined us, we do a little sort of resetting for our guests, for people who are coming in and out of the car and getting in late. Kevin, this is a device called a Morcellator.
That's correct.
And as a result of the use of that, there was cancer in Dr. Reed's body, and this device basically shreds up the tumor, but spreads it. It made the cancer spread through her body. Is that?
That's correct. Now, the device isn't used for cancer. It's used, they think it is for a fibroid, removing a benign a tumor that grows in a woman's body. But if they do have cancer, which can occur in 1 in maybe 300 people, it will spread it and becomes a upstaging, or something that was very treatable and curable, is something that is a huge, serious problem.
And Dr. Reed, you had no idea that this was a possibility?
No. In fact, we had gone, we went to a top gynecological oncologist. So this is a surgeon who deals in cancer of the reproductive system of women. And we went to him, and he said very clearly, you do not have cancer. At that point, I had ultrasounds, I had an MRI, and I had an endometrial biopsy. So by all accounts, I was free, about as free and clear as you can get. There was no evidence of anything out of the ordinary. I would like to amend my prior comment, though. One of the listeners asked me about removing endometrial tissue. Endometrial tissue can sometimes grow in the abdomen as well, but it's unlikely a Morcellator is used then. However, Morcellators can cause endometrial tissue to spread. So, but getting back to your question, no, I did not know at the time. Cancer was the furthest thing from our mind when I had the surgery.
And the thing to consider is that prior to the publicity that came as a result of Amy's complication, the gynecologists were considering this practice a sort of a routine and technical detail of the operation. It was never discussed. It was if any clinician did discuss it, it was a rarity. This was something that was considered a minor technical detail of the operation, and the assumption had been made that these uterine fibroid tumors are benign. And that was sort of the professional mistake, this assumption of benignity about uterine tumors.
It doesn't seem, I'm sorry, Kevin, you're chomping to ask a question here, but that seems so weird to me, because if you get any kind of little anything removed from your body, it is routinely checked to make sure it's benign. I mean,
And in fact, when the tissue was removed from Amy's body, the tissue was examined pathologically. The issue is that prior to the operation, the surgeon has to make certain that the tissue that they're dealing with is non-cancerous, especially when it's a tumor. Now, for reasons that we can discuss, the gynecological specialty was making this assumption that these fibroid tumors inside women's uteruses or uteri are benign. This was a function, I believe, of the non-liberal type education gynecologists get. And what I mean by that is that in the gynecological specialty, there is no formal training in general surgical principles. So in other words, if you go to an ENT doctor like Kevin, or if you come to a cardiac surgeon like myself, or even a plastic surgeon, these folks have all gone through several years of general surgery training, where there's a broad education in general surgical principles. This was a complete and clear violation of a fundamental surgical principle, which is that you should not mince up tissues, tumors, that you do not know the malignant potential of. Okay? That's a fundamental surgical principle that no other surgeons violate.
You're absolutely right. In young women, if you present with a breast lump, and even in young women, the incidence of you having that lump be cancerous is on par with me and walking into my my OBGYN's office and having this uterine lump. But no breast surgeon would ever consider chopping that up in a way that could potentially spread it if it were cancer.
Yeah, and just to add a little bit to that, I can tell you in training as an ENT doctor, and I was a head and neck cancer doctor for several years, you do great lengths to avoid cutting into any growth or tumor just with a knife. In fact, if you do cut into a tumor, I mean, that is absolutely a disaster. You feel that it's malpractice or extremely bad practice, that you've probably killed the patient, et cetera, et cetera. Well, this doesn't just do a single cut. It puts it into a meat grinder in the abdomen, and then you suck it out. I mean, it's just unbelievable. And the other thing I wanted to add is that, but what it does do is allow a small incision and cut down the surgery time so you can do more patients per hour, do it at a surgery center, and generate a lot more cash, too, by doing this procedure.
Absolutely. I mean, the issue is that this feeds into two, big desires. One is a corporate desire, which is to streamline and increase efficiency. It's a very clearly very efficient machine. And number two is it feeds into this desire that many people in our society have for, if you will, more bang for your buck, if you will. So in other words, the ease of the operation, the vanity of, having a small incision, all these things sort of feed into it, and so it's marketed quite effectively and efficiently. But the cost of it is to a minority subset of people who have these missed or occult cancers. And so the question, for us as a society and as a profession is whether we are at a place in the year 2015 to accept that these sort of corporate objectives, if you will, are it's justified. That the people who sort of fall through the cracks, the minority subset of people who fall through the cracks of these corporate objectives, their sacrifice is justifiable. And that's a question that we ought to ask as a society. Here is a subset of people, a minority subset of people who are not, in any way identifiable based on their socioeconomics or their race, or perhaps they are by their gender. But here it is. We've identified a minority subset of people who are being affected, devastated. And the corporate objective is to justify their sacrifice for the benefit of the majority. Now,
because they're a minority, yeah.
That's right. And this is where I think we ought to discuss with the points of failure and what the role of the federal government is in protecting every single individual. And I think what we've come across is that the federal agency that's responsible for regulating these devices is an absolute disaster, frankly. And I hope we can touch on the 510K legislation and medical device approval at some point.
I want to ask, since we're talking about money here, if a patient has this done, gets cancer, is there any recourse that they can take to get their bills paid for?
Well, this comes to the question of medical malpractice, and here's how medical malpractice law works. In order for a patient to seek damages, they have to prove a breach of standard of care. That's basically the law of the land in most states. So in other words, a patient has to demonstrate that they got hurt because a surgeon or a doctor violated the standard of care. So here's the catch here, right? This was a standard of care. So it's possible that the majority of patients would have a very difficult time seeking damages. Now, the twist to it is that informed consent is clearly violated here. So the majority of surgeons who were doing this were not providing informed consent to their patients, and that basically classifies as assault and battery. And so I think this will have to be vetted out in the civil court system, and it will be, I think, over the next 2 years.
Yeah, in the other.
And Kevin, I'd just like to point out, I mean, a lot of patients like myself and thousands of other people who have struggled with cancer can relate to this. I mean, you're running back and forth with doctor's appointments, chemotherapy appointments, scan appointments. The people who are hurt by this don't necessarily have the time or the headspace to engage on that level. The bills get thrown in a pile because you're not feeling well. Mm-hmm. So even if you do have the wherewithal to be able to attack it at that level, you could get absolutely nowhere based on the things my husband just pointed out.
And this is exactly where the federal government needs to sort of stand up and look at what its framing purpose has been. I mean, this is the one thing that this really tuned us into, is the fact that our federal government is deviating towards streamlining itself with industry and corporations. Meanwhile, people who are getting hurt, people who are in harm's way, you know, have absolutely no voice in a democracy. So there's a dissociation between the democratic voice and our federal government's actions. Our federal government's more aligned with corporations at this point.
Yep. Go ahead.
Yeah, and I also think you need to remember that when it gets approved through the federal government, doesn't necessarily mean it's tested or safe. The 510K process does not require testing. And so that is a huge problem.
Talk about that when we come back. Dr. Kevin Cavanaugh is in the studio with us. Dr. Hooman, Noorchashm, and his wife, Dr. Amy Reed, are on the phone. And you said something about 510K.
Yeah.
What the heck is that?
Well, that's a very rapid, short approval process where if your device is the same as a predicate device, the FDA approves it with minimal or no testing. Now, when it says just about the same, believe me, it's sometimes it's like, you know, comparing a cow to a chicken, and these things are getting approved. The predicate device and being substantially similar is very liberal in its determination of what can be approved, and that's one of the, I think, huge problems. And so these devices are coming on, whether it's a change in the hip, whether it's a retrograde endoscope, or whether it's a Morcellator with virtually no testing. And unfortunately, my understanding is once it gets FDA approved, patients really don't have any recourse against the company. They're protected. And ideally, you would think, well, it's been approved, it's been looked at by a number of scientists, it's had research studies, research data, and this device in itself has been used many times on people in a research setting. That's not the case with the 510K approval process, and the majority of devices are now going through this channel. So it's a huge problem, and maybe you can talk about this a little bit more.
Absolutely. I think it's very important for your listeners, Jack, to understand that the vast majority of medical devices that are used in our hospitals across the nation are neither safety tested nor are they subject to any sort of consistent adverse outcome surveillance mechanisms, and very certainly the user facilities are not taking the self-reporting mandate very seriously, so that the first time after 20 years of this Morcellator spreading cancer in women that it was reported was in December of 2013 when I reported it to the FDA. Now, imagine that, right? So you have a device that's basically spreading cancer at a rate of 1 in 300 in women for 20 years, and folks knew about it. It wasn't like nobody knew about this. It was just sort of this complacency that was going on. No one self-reported. So I think the listeners have to understand that because of a specific piece of legislation called 510K, and again, I'm going to repeat the name of this thing because I want everyone to hear this, to understand that we have a federal legislation called 510K that's governing an entire sector of the healthcare industry, the medical device industry, that essentially is not a risk-based mechanism for ensuring patient safety. It is essentially a fast marketing mechanism that buys devices, guaranteed path to market using an FDA label, and when it hurts people, the cost is paid by individual families, individual patients, as well as by our health insurance infrastructure. And I would venture to tell you that if in the year 2015, when we look back 10 years from now, if we've solved this problem, this will be one of the top 3 reasons why our health insurance infrastructure is taking a hit. Because every single device in this country has the potential for causing harm because it is not being safety tested in a standardized fashion, and adverse outcomes are not being reported to the market, to the FDA. Therefore, dangerous devices stay in the marketplace, cause harm at cost to families and at cost to our health insurance infrastructure.
And it sounds like to me there's some culpability with the medical professionals that have used this device knowing damn well what was going on and didn't say anything.
Well, yeah, that's a huge problem, and you can look at that in many different issues, but self-reporting just doesn't work. It doesn't work in infectious disease. It doesn't work with medical device reporting of problems. There have been studies that, that less than 10%, some studies less than 2% or 1% of problems that occur ever get reported. it just isn't a good mechanism to assure safety.
Amy, Hooman, unfortunately, we are out of time. God bless you both. We'll pray for your full and complete recovery, and thank you so much for being with us this morning.
Thank
Thank you.